Now that can, because of the muscle spindle's ability to adjust and adapt, that can change. When a muscle is irritated, strained, or if it's not getting enough inhibitory signals from its antagonists and from the other the inhibitory parts of the brain, the muscle will set too tight. If a hypertonic muscle, tight muscle, will usually muscle test fine in the clear. It'll test as if it's completely normal. The way to tell if it's too tight, there's several ways. The easiest way to do it is just give it just a gentle stretch. Enough to where the muscle really knows it's stretchy, and then immediately retest it. If it's hypertonic, it will go weak. It won't tolerate that because it throws its whole tone set mechanism off. That's the, I guess, the bottom line on that. So nothing stretching is awesome. And if you have a hypertonic muscle and you engage in a stretching exercise that, you'll change the tone set of that muscle. We've all done that. We stretch out our hamstrings, feels pretty good. But then if there's an underlying issue, and usually like hamstrings are a great example. It's an easy example to talk about, but because everybody's got tight hamstrings, it seems. Tight hamstrings, you stretch out, they feel better. But if the quads have a problem, quads aren't firing well for any number of reasons, then the hamstrings aren't getting enough inhibitory signals to keep them normotonic. So they're tight. So you can stretch them out. They'll feel great for a day or two or three, but whatever activity, if there's an underlying disruption in the way those muscles find their tone set, that tightness will come back. And it's often considered the whole, physical therapy, massage therapy industry is based on tight sore muscles. There's no shortage of them for people to work on, right? But if the hamstrings are tight every day, there's a problem. That's not normal. There's other reasons why the hamstrings can be tight. It can have to do with weak glutes, which are synergists. They're sort of in the same kinetic chain as the hamstrings. There can be problems with the back. There can be a lot of different reasons why the hamstrings are tight. But one of the most common is that the quads are weak. And when I say weak, they're not functioning optimal. My savior. Does that answer your question? Yes, more information we probably asked for, but that's why. So yeah, there's another way, and we're going to get into that when we get into muscle. Thank you so much. I'm actually done. Somewhere. There. There's another way to do it. When we get in, we're going to be doing muscle spindle manipulation today. You can spindle a muscle down, and a hypertonic muscle, a normal muscle that tests strong in the clear, you spindle it down and it will go weak for just a second or two. And that's a good sign. A muscle that tests weak in the clear, typically you spindle it up and it'll turn on for a second or two. And that's a good thing. Dr. Wally Schmidt would always find a weak muscle, and the first thing he would do is spindle it up, and if it didn't turn on, then he knew he had a higher order problem, like a neurological issue called IRT. We'll get into that later, different sessions. But one quick way, if it isn't convenient to say we were doing a gluteus medius, I think was on you, wasn't it? We were doing yesterday.
I think so.
Yeah, and so we would test normal, give a stretch, goes weak. Say it's just not convenient to do that. Maybe like a glute max, patient's face down. It's hard to get them off the table and stretch that and then test it quick enough to see if it's going to weaken. So with the glute max, you can spindle it down and then retest it, and it should turn off temporarily. If it doesn't, then you've got a hypertonic. So that's another way you can determine if the muscle's hypertonic enough or not. And there's a real there's times where it's really helpful to to determine if you've got a hypertonic. Some of the AK folks, I think, are really, they go a lot more into muscles that are hypertonic. I don't know. It's never gotten as much traction with me. Yeah. So some will claim that, like, if a person is reacting to certain allergens, they're going to go hypertonic. There's all kinds of scenarios. I just don't go into that too much. Maybe I'm missing something. I don't know, but I can fix hypertonic muscles usually by clearing the weak ones. And then I do a lot of PNF. I'm really a big fan of PNF stretching. Those of you who are massage therapists probably know PNF, and it's a great way to. It's like basically you're helping the patient stretch and having them contract the antagonist while you stretch them. So it's a mechanical stretch, but it's also a neurological reset. So and then I teach patients how to do their own version of PNF. If they're doing a hamstring stretch, everybody does this, right? Stretch, 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 which is fine. But if you lift the leg, if you activate the rectus femoris and the quads as you stretch, now you're not only mechanically stretching the muscle, you're also neurologically resetting the reflex loop. And patients that do that, a lot of patients stretch all the time. They know it helps them, but if you teach them how to stretch that way, it's much more efficient and effective. So, great question. Any other questions? I'm input driven, kind of like a computer. So the more questions you ask me, the more I can spit back out. Did you have a question? Or you just? So you have
intuitively, like when you stretch, if you're rolling out your back, is that always a good thing to just follow what feels like it's tight, or is it possible to hurt? Like, I just get mixed opinions on how much you should like roll out your back or put pressure on your spine, like on your own.
Well, I think the body has a very good feedback mechanism. So anyone who's done much in the way of stretching or sports or yoga or body, those kind of things, one of the key elements to those approaches is to learn how to listen to what your body has to tell you. And there's pain that's sort of like, yeah, it feels good, kind of hurts at the same time. That's usually very safe. Pain that feels icky and painful and burny and teary, that's your body saying, this, I'm not happy with this at all. And you might be doing a beautiful, stretch, but and it may look like but if you're feeling that pinchy, burny, unhealthy pain, you're hurting your body. And I've hurt myself doing yoga many times. Usually when I'm teaching, I'm doing the pose and I'm blabbing on, I'm not paying attention to my own body, and I've hurt myself a few times doing it over the years. Does that answer your question? Yeah, but a lot of our patients don't know how to listen to their body. They've spent much of their time learning how to ignore pain, and it's encouraged in all kinds of settings, So everyone's different. Some people are super sensitive and they need to maybe put up with a little pain, but a lot of people are just not tuning in to their pain, and they have to. Part of my treatment is trying to teach them how to look at their relationship with their body, and of course with the signals that it tells them. And a lot of people don't even know they're constipated. They come in and, how's your digestion? Oh, fine. And then you start palpating, they're just constipated as heck. And, but they don't know. They're just used to feeling kind of full and bloaty, and everybody, and their doctor said, oh, it's normal to have a bowel movement every 4 days. And I hear this all the time. Yeah, I told my doctor, I asked them about it, and no, it's fine. People don't have to have bowel movement every day. Where do these people get trained? Like, if you eat every day, you should have a bowel movement every day. It kind of makes sense. Look at your dog, your horse, they poop every chance they get. Sometimes inopportune times, but if in doubt, poop. That's kind of how a lot of dogs are. So we talked about therapy localization. Any questions on that? We haven't really done it yet, but we're going to play with it today. And part of that too is a lot of it is how you TL. I know that yesterday there were some questions about some clarifying questions about TL versus challenge, and we're going to challenge vertebrae today. And any kind of challenge, even if you just traction the skin or push it a certain way, is a challenge. Having the jaw opening, closing, biting down, like we did yesterday with you, that's a challenge. Basically, anything where you involve a receptor is a challenge. Tooth, we can challenge teeth, we can challenge all kinds of things. But TL doesn't involve any kind of distinct pressure, and TL doesn't tell you what's wrong. It only tells you that there's something going on there that's energetically disrupted. That's all it tells you. Then you have to go into challenge or all your other investigative techniques to find out what's wrong. So it is important, I think, to use more than one finger because the fingers have polarity. 2 to 3 fingers, I think, is really good. Dehydration can affect TL. If a person's dehydrated, sometimes you're just not going to get good, clear signals. Holding the breath for 5 seconds. Dr. Francis used to teach this. I've never found this to be that helpful, to be quite honest. But if people aren't breathing, a lot of times they won't TL well. If they're not breathing, they're usually holding their breath, and they usually have cranial problems. They usually got cranial issues, pelvic issues, diaphragm issues if they're holding their breath when you're testing them. But he used to say that if you're not getting clear TL, have them hold their breath for 5 to 7 seconds. You can try that, but honestly, it's never. I've never seen that to be that helpful, just in my own personal experience. Palmar. We use the palmar surface of the hand. We use a flat hand. We use 2 to 3 fingers, or you can use the whole hand. If you're going up into the neck, like specifically in the neck vertebrae, you might use 2 fingers. That way you cancel out any polarity or any polarity, thing. And it's gentler. It's a broader contact, and you can get in there a little. Like we did with some of you yesterday, we had to do like a whole TL over the neck. And we got a change in the muscle. That doesn't tell me anything other than it's in the neck. Then we have to get real specific and then start challenging. You can use sometimes you can use the dorsal surface. The dorsal surface of the hand's not as electromagnetically sensitive, but in some cases, you can try it like this. Say there's a problem there, but you're not. It's just not showing up. Have them do this, and then have them do, and sometimes they'll show up. But mostly, you want to use the palmar surface.
Sometimes just like polarity for whatever reason.
Yeah, I think there's the energy. If you look at some of the Curlian photography, the energy coming off here is stronger than back here. It's amazing how much. If you guys ever seen the homunculus, that image of there's a sensory and a motor version. I have somewhere. I've got some slides of those, but you look at the face is enormous, right? The lips are huge, the tongue is giant, the hands are giant, and then the spine is like this big. So that's how the brain sees the body, the sensory part of the brain. It's getting all kinds of data from the hands, the face, different places, and proportionately very little from other parts of the body. And so I think it's helpful to kind of think or appreciate how the brain sees us, our own brain sees us. It's different than how we see ourselves in the mirror. This is, this is called enhanced TL. Sometimes, especially with visceral stuff, it's really helpful to put both. Now you've got even more energy there to kind of intermingle with body energy. I find this really helpful with visceral work, this enhanced TL. And this is typically how I use like the voice, I guess, is that Boy Scouts?
Yeah.
3 letters? Yeah. I was never a Boy Scout, so.
On communicator side.
Yeah. There's, common, now there's where you can do enhanced, so enhanced like, getting that later, but a lot of times I'll have them do an enhanced TL like that, or if they just have one hand, I'll have them do like that, and that kind of adds. But, most of the time, this is going to work just fine. Oh, here's the lower, can we go over the muscle slides? Are you guys seeing? These are the muscles that we learned yesterday at the end of the session. We'll go through okay. We get these that way. So we any questions on any of the muscle tests that we did on? One of the things I want to say about hold on just a quick second here. I gotta have some of my cough in here so I can talk faster.
Argument, there are 2 copies.
What's that?
2 copies.
That's like what do you call it? Vente. It's good. It's filling up your space. One of the things I want to say about muscle testing, you guys already know probably more than you realize you know, especially those of you who have backgrounds in training and massage and sports and all those things. If you spend a little time really understanding the actions of all the muscles, you really understand what they do, you could muscle test just about anything. These muscle tests were invented, conceived of, by people who just studied movement and then figured out a way to test them. And so there's an ideal way to test each muscle. There's an ideal way to have your body positioned, which hand to use. All that can really make it more efficient, more reproducible, more comfortable for the patient and especially the examiner. But don't forget to, when you get ready to test a muscle, think about what that muscle does. That's one of the first things you want to think about. You test pure. Like yesterday, we were getting a little dyslexic and talking about piriformis. It's like, well, that's internal. No, that's an external. So this, piriformis is an external rotator. So the way to test it is to let the muscle do its thing and then try to take it out. Whether it's a piriformis, a teres minor rotator cuff muscle, for example, it does this. It also does this in all these just different positions. But up here, you've got teres minor and infraspinatus and a little bit of posterior deltoid. You've got a bunch of stuff kicking in. Here, you're more specifically teres minor. So in this position, you have the teres minor in a contracted position, then you try to take it out. So you wouldn't even necessarily have to learn that muscle test if you know that that motion and how that muscle works. You wouldn't necessarily even have to. You could just test it the way you intuitively. So don't overthink it, but realize that you've all had biomechanics, right? You've had anatomy. You've all had really good anatomy training, I'm sure. Naturopaths and chiropractors have some of the best anatomy training of anybody. I mean, that's one place I think where our education really shines, is in anatomy. So anyway, here's the muscles. Piriformis, one of the important muscles for low back and pelvic issues. Often overlooked. There's a thing called piriformis syndrome. I'm sure you guys heard of that. It will cause a form of sciatica that will act just like a hot inflamed disc, like a nerve root. irritation. I see these all the time. I find the piriform, I mean, it's much more common than I think the literature suggests. Because a lot of people don't look at the piriformis. They go straight to spine. They're looking at, you know, SI. But piriformis, its job is to, here's the job. Its job is to maintain integrity between the sacrum and the back part of the bigger trochanter. So it's an external rotator, but more importantly, it's a stabilizer. It stabilizes that relationship between the hip and the sacrum as you go through all your big motions. The glute max is the most powerful muscle in the body. It's very, or should be anyway. The glute max is where we get all our power, lifting, pushing off, but it's a big kind of gross movement. You need these other muscles, the piriformis and these other, the gemelli and some of these other smaller hip muscles. They maintain the position of the hip joint. So if one is hypertonic and one is weak, you've got a, and when somebody has a sacral subluxation, fixation, if the piriformis didn't cause it, which sometimes it didn't, it's the piriformis is now maintaining. Piriformis will adjust and it'll hold that sacrum in subluxation until you fix it. It's related to the pericardium meridian. I don't tell patients that they have a problem with their, I used to say, oh, what's that? Well, that's your circulation sex. And as soon as I say sex, it's like, whoa, what's that mean? You know, and so I just say pericardium. That way I don't have to, you know, entertain their reactions. I think it's also got some heart
Triple warmer, triple heater, triple warmer.
Triple heater is different. It's related to the thyroid, but pericardium is the one.
They're all like fire.
They're all fire. 4 fire elements. Yeah.
I usually just say it's associated with your hormones. Like,
yeah,
stay away from using the word sex.
You're right. Yeah. There's key words that you just got to be careful with patients that it's like their minds go off and then you got to pull them back into the conversation. Sex is one of those words. Piriformis, the interesting thing about the piriformis is the sciatic nerve crosses right underneath it. And then I've seen cadaver studies where they found that in probably roughly 30-some% of cadavers they looked at, the sciatic nerve actually coursed through part of the fascia of the piriformis. And so if the piriformis gets inflamed or hypertonic, it can cause ischemia to the sciatic nerve. And people who have, and you don't know, you just do an autopsy if they have their sciatic nerve running through the muscle. But that, of course, narrows their margin for error. So they're more likely to get piriformis syndrome, it's believed, than if not. Yeah. So patient, I mean, it's just an incredibly important muscle and very small, very oft overlooked. You guys learned about sacral subluxations in phys med? You talk much about the same.
Like the SI joint, more on like the SI joint, not necessarily on the sacrum itself.
I can't get over here. So anyway, yeah, just what I just said. You can trap the sciatic nerve and cause all kinds of issues. The way to determine if you've got a true disc issue or a piriformis syndrome is test the piriformis. Test it for beaconing, and that's one it's really handy to test it for hypertonicity too. Palpate it, just push right into it and see what you find. Also, your classic Lesiegs, straight leg test to stretch the nerve roots, looking for a disc problem. A lot of times they won't have a positive Lesiegs. Now they might have if the sciatic nerve isn't inflamed, you'll get reaction, but it's different than a classic, disc nerve root thing. When you see a disc, a real disc, like a true blue, like herniated inflamed disc that's causing nerve root impingement, it's kind of like, it's like, it's very distinct. Now, chronic discs can drive you crazy, but a hot disc it's kind of like a rattlesnake. I grew up in rattlesnake country, and so you're always watching the ground in the summer for snakes. And you'll see a bull snake, and you'll see a garter, But then when you see a rattlesnake, you immediately know it's a rattlesnake. Somehow the pattern of the skin, of course, the rattle gives them away too, but discs are like that too. When you see one, it's the real deal. And piriformis syndrome is like a bull snake. A bull snake. You put them, geese can kill rattlesnakes too. People used to keep, some of our neighbors used to keep geese around their property, around their gardens and stuff, because the rattlesnakes wouldn't come around, because the geese would kill them. And they couldn't strike through the geese. They couldn't hurt the geese. Yes.
On the previous slide, it says the femur is externally rotated, and the one before it says it's medially rotated.
Oh, God. Okay.
Which one?
Another slide. I need to, medial rotation of the femur.
Oh, that's if it's weak.
Yeah, if it's weak.
If it's weak,
Yeah,
then
if
you're
needed, yes.
gonna
Oh,
internally
yeah.
rotate because you lost the ability to externally rotate. So it'd be like if they're standing, you have people who will stand like this and who walk like this, like kind of like a duck, right? That's like their piriformis is working tight. They're stuck or hypertonic versus if they're a little more like internally rotated, it's the weakness and they don't have the ability to externally rotate. Yeah. That would be like an extreme thing. That's why you watch them walk, because then you can kind of see that.
A few years ago, there's a movie, there's a couple of movies about Steve Jobs after he died. One of them was Ashton Kutcher played Steve Jobs. I thought he did a fantastic job. And Steve Jobs had kind of toe-in gait. He'd walk kind of fast. And Ashton Kutcher mimicked that. Every time he walked, you see him kind of, it was like both piriformi weren't firing too well. But yes, so that answers your question, right? A lot of things can cause this. The knee will laterally deviate in a tight one. You'll see people with short leg, with an anatomical short leg, because their pelvis and their muscles are always trying to compensate for that. A lot of times they'll have an uneven toe in. Like one piriformis will be chronically tight. And those don't always respond that well. You try to stretch them, and they're not always that easy to change. Sometimes you have to kind of leave some of their compensatory patterns in place because it's serving them. That's how we test it. We learned that yesterday. Knees, this the supine test. Make sure they're at 90. And this is Dr. Mike doing the prone test. He stabilized. That's kind of nice. You can do that. If they have an injury there, you might be careful. If they're super sensitive, you can go up onto their low back. But the Chapman reflexes they share with gluteus medius and some of the other muscles right at the L5, S1 junction there. Those are the Chapman reflexes for, and when Dr. Whitney brought the AKA chart, so we got a quick reference here. Here's all the Chapman reflexes, and here's all the meridians, and here's the alarm points that, when we get into tested meridians, we got pulse points, foot reflexes, you've got the Shannon co-cycle, all kinds of cool stuff here. And this chart will tell you the nerve supply, all kinds of stuff about it.
Nutrition.
Nutrition, yes. And yes, these charts, I don't know what they charge for these now. ICAK
So like 50 or 60 bucks, I feel like,
50 or 60?
maybe. But again, like if you guys put it in a big book order, we used to do order and charts if you wanted one. And I think, don't quote me on this, it might give you a bulk discount for students.
If they don't offer one, ask them.
Yes, always ask.
We're students.
Yeah. But I mean, I have most of that memorized, but I also reference it all the time.
I use my own.
And patients love it. They love to see it and they'll be like, oh, what does this mean? And then eventually I get to the point where I'm like, can't memorize anything that I could, like, if I can look it up, I'm not gonna memorize it. So the chart is also nice for that.
They're
You
fantastic.
do have to know all that for your test, but
Yeah, exactly. Yeah. So
eventually your brain.
pretty much if you know
Yeah.
most of this, you'll pass the 100-hour course and the 100-hour test. So you don't even have to take the course, just memorize this chart and then take the test, right? Anyway, so Chapman reflexes for the piriformis, parietal eminence. There's several muscles that have their Bennett reflex at the parietal eminence. This is also the posterior temporalis muscle. We did a little TMJ work yesterday. We didn't get into the temporalis, but the temporalis comes clear back into there. So a lot of times TMJ problems will cause cranial problems more than anything else, I think. Imbalanced gait and TMJ problems cause more cranial problems, I think, by far than anything else. I think cranial problems and gait cause more TMJ problems than malocclusions. I'm sure there's lots of dentists that would argue with me, but they approach TMJ, the ones that actually treat TMJ, they approach it from this purely there's something wrong with the bite, but they don't usually understand how to look at the too much. They're not trained in TMJ, unless they go to special fellowships. They're trained in just base, and they cause a lot of TMJ problems. Patients that every time they go to the dentist for a cleaning, they make sure they have an appointment with me afterwards because their TMJ goes wacky and the cranials go wacky. We've kind of figured out a way to fix that.
I had a patient who got a filling and it messed up their whole bite.
They'll throw their whole body. Yeah. Who was it? Oh, you were talking about that patient last night.
What about it?
The one with the migraines.
Oh, no.
No, oh, the braces. Yes, you're,
Oh, yeah, they were like,
oh,
oh,
that's
migraine's normal.
normal.
Yeah. They're like, it's
Just deal with it. Look,
It'll stop eventually.
yeah, it'll, yeah.
Well, because I really think they only look at the actual teeth and the bone. They don't really actually consider that the muscles move the bone.
Exactly, and malocclusion is often a result of the TMJ. Like with you didn't have much, but you had a little bit of your vertical dimension was different side to side, and that's a type of malocclusion. So the TMJ was causing malocclusion, not the other way around. I had lots of patients that go, they've had teeth filed and all kinds of stuff, and it doesn't fix the TMJ. I mean, it usually doesn't work. So anyway, stress receptors. Okay, psoas muscle, also very, very important muscle. Probably if you got really good at testing psoas and fixing the psoas and the problems that are associated with psoas, you can help a lot of your low back, pelvic people, patients, that is. So the origin is extremely long and complex. It starts out, this part actually interdigitates with the crura of the diaphragm, the muscular slips of the diaphragm that anchor down into there, into the lower rib fascia.
How do you, like, origin insertion, like, how do you work with that muscle? It's so deep in there.
You don't. I mean, not really. I mean, you might be, if you're really invasive, you might be able to get a little bit on the insertion. I will often, I'll put the knee in a really slack position, and if I can work myself, down through the innards, I can maybe get on the part of the psoas. You can get into part of the iliacus a little bit,
I work
but it's
with
a very
iliacus
difficult.
more often.
Is that,
the iliacus more often.
you can get at it somewhat, just like
Easier and it influences the psoas pretty good.
It does, yeah. But yeah, as far as direct soft tissue work on that. The interesting thing too about psoas, it's hard to exercise consciously. You know, like these muscles, real obvious, you can isolate them and exercise them. The psoas, it's always work. It's kind of hard to, you know, I guess you could do something like that, but it's a hard one to, you know, consciously exercise.
I always think of it too as like, I think too, like it is just one of those stabilizing muscles. So I always approach it as to like, why is the psoas tight or why is the psoas off? So when we start to look like spring strain and other stuff, we'll figure out, well, if you fix all the other imbalances, then the psoas will usually come back online. So you don't always have to directly fix the muscle, but they're influenced by the function of everything. So as you correct it, the psoas I find will naturally correct. So you don't always have to like tackle that one, or just make sure you're asking why, like, what is the pattern? Why is this off and how else can I fix it?
It's very sensitive to all kinds of other things.
Water.
Water,
That's the number one thing I think that fixes a psoas.
yeah, kidney, meridian, kidney organ. It's when people talk about core strength, you know, psoas is one of the first things I think about, the core strength. Because it is, and the interesting thing about, we have some stuff on the action here. So it has two primary functions. In open chain, it's a hip flexor. In closed chain, it's a lumbar lordosis maintainer. So it's tethering the vertebrae from, you know, diaphragm down about halfway down the lumbars. It's kind of pulling those forward like this. So that it's really important for proper posture. If the psoas weakens, this happens. So, and of course, it's if you're walking, moving around, it's alternating between an open chain hip flexor and a spinal stabilizer. In splits, you know, runners, it's going between stabilizer and prime mover, you know, and splits that for, you know, many miles. So it's often a problem with athletes, especially endurance athletes. One of the first things you want to look at. A lot of times you'll have a runner that is just fine for 2-3 miles, and then by 6 miles, their back's killing. And that can be a number of things, but one of the first things you want to look at is the psoas. Question.
Is there any nutrition for the piriformis?
Oh, yes. Yeah, nutrition would be anything to do with hormonal support. And so vitamin E, of course, is going to be most likely on the test, maybe. Dr. Francis used to, if someone was on the test, he'd say it 3 times. But vitamin E is kind of the top of the list, but anything that supports hormonal nutrition, essential fatty acids, of course, very important. A lot of the nutritional, where's our test?
Oh, they're
We won't need to run a second, which I just. One of the most common things you'll see with psoas is with posture is you'll see it like a tight psoas. You'll see, just like you will with a tight piriformis, you'll see an external rotation, but often you'll see sort of a lumbar sort of thing like this. You see patients walk in like this, you know, see those. One of the things that's pulling them over like this is their psoas on the right. And so that psoas is doing its best to try to hold that back together. And it's usually not a problem, but it's, and a lot of times if you can get the psoas to balance out, and as soon as they stand up, if they've got certain kinds of problems, they go right back into it. So, short stride, we're going to do posture and gait analysis a little bit later today, which is one of my favorite things to do. Yeah, stabilizer. Yeah, causes torsion, opposite diaphragm imbalance, breathing issues. Psoas is a muscle that's super sensitive to the breath in, breath out screening. And a lot of times we want to go to cranials, but often with the psoas, it's diaphragm, lumbar area. If it strengthens on an in-breath, there's often a diaphragm thing going on, which to me is as much a part of the craniosacral mechanism as the sacrum and the cranium. So anyway, kind of stuff already said. Here's Dr. Rob. It's about 30 up, 30 out. And you can get very creative with, they say 40, what's that? So abducted 30, external rotation, and about 30, 35 degrees inflection. That's how I do it. And, you know, you can test it way up and way down, but you start with that. That's the main test. And then if it's weak or if it's strong there and you really think you've got a psoas issue, go ahead and test it through its full range. And you might find something. Back to the full. You got a lot of leverage as an examiner. It's a big muscle, but you've got a lot of leverage. So make sure you hold them in position, make sure they can hold it on their own, and then gently start to test. You don't need much pressure with this muscle, even though it's super big. Oh, like the raise my hand. The Chapman reflexes are in the front. They're about an inch out, an inch up from the umbilicus. Posterior, they're right between T12 and L1. Right in there, right about where the bottom of the diaphragm crura anchors. Diaphragmatic crura. If you look at your, I have any slides that show this, but well, also when we get into fixations, you'll find this interesting. If you have two weak psoas muscles, if they're both weak, and one of the first thing we did this on somebody yesterday, but I didn't really explain it. Have your patient therapy localize the occiput, because very often you've got an occipital fixation that will cause a bilateral psoas weakness. Likewise, if you have both glute max muscles weak, it can be a lot of different things. But one of the things you want to check is an upper cervical fixation. So if you think about how gait is, how the body carries out gait and different body positions, the body once again has to turn off certain muscles in order to function. Otherwise, we never move. When we look up like this, which we're sort of mimicking an inferior occiput and occiput jam this way, which is very common in our society because of this. Some people, their occiput's jammed like that for years. So the brain thinks you're looking up. And so it tells the psoas muscles to inhibit, to allow this. So, I mean, that's a kind of overly simplistic way of looking at it, but if your occiput's jammed this way, you're going to be turning off the psoas muscles. It's not that simple, probably, but that's one way you can kind of think about it. Psoas vitamin A. Is, you know, you're concerned about the test, but also anything water. Dr. Whitney says water is probably the first thing you want to look at. The only lab I do nowadays in my office is I do CDL physicals for the federal CDL certification, and I have to do just a urine screen on those guys. But I would say about 1 out of 12 of the drivers that I do these on has a normal specific gravity. The rest are all higher. It's like their specific gravity is higher. They're somewhat dehydrated. Some of them way at the top of the little scale. So, and they're a pretty good cross-section of the normal population. The guys I used to see, in the old days, a lot of the drivers I did were really bad shape. I mean, smokers, drinkers, and these guys. But for a number of reasons over the years, the clientele I have now, because I do the physicals for several big companies, most of these guys are in pretty good shape. They're younger, they're more health conscious, and I don't see a lot of the problems that I used to see. I used to have time passing some of these guys because of blood pressure and blood sugar stuff. But overall, I think what I see now, that group is probably a little more representative of general public than my patients, who are kind of maybe they all have problems. Some of these guys have problems too, but they're not patients, so I get to observe them without having to try to fix them, which is nice. But dehydration is super, super common. Coffee, soda, all those things dehydrate us.
Yeah, I would say my general population is pretty healthy. They're just tired and have pain. So my first go-to is water, and electrolytes or salt. Like, make sure that they're actually being hydrated by the water. Because on average, I would say I don't really find a lot of actual kidney issues or reasons to support the kidneys unless, they have chronic UTIs or something like that. So water is usually fixes it. And then if it keeps coming back, then I kind of dig deeper.
I have a few patients that have one kidney. Several that have one kidney. So it's always interesting to test the psoas and of course the upper tract because it's kidney related. Like several patients, they have one kidney and only one adrenal gland. So, question. Oh, yeah, sorry. There's certain muscles that are considered more ideal for when you're doing food toxin or food protein testing. The psoas seems to be particularly sensitive to dairy issues, and not just lactose intolerance, but also in case of intolerance. Well, if you're going to be testing, say, if you're going to be testing for food intolerances or allergies technically, of course, are a reaction to a protein. So lactose intolerance is not an allergy; it's a different kind of thing. But if you're doing testing on a strong psoas and you want to test them for dairy, that's a good one to test to see if it weakens. Pectoralis major sternal is a good one for gluten. According to Dr. Francis and a few other people that I learned from coming up. Any small intestine related muscle like the quads are good for well, they're good for gluten too. Something else, I can't remember what it is that they're good for. I got to do something. Brain related muscles like the supraspinatus, he said were good for corn sensitivity, corn zine, which is the peptide in corn that react to. So, I mean, you just file that. That won't be on your test, but just file that away. And when you get into a situation, you can remember that. But I don't use psoas much for food intolerance testing. It's just too big a muscle. It's too tiring because when you're doing testing for nutrition or food and toxins, you need a muscle that you can test gently and a lot of times. That's very convenient. And so psoas is, but yeah, that's what we picked up. So I did. Gluteus maximus, strongest muscle in the body if it's firing well. It's the largest single muscle in the body. It's a hip extensor and a little bit of an external rotator and a little bit of an adductor. It is, I test it on everyone that has low back problems. I tested on everyone, often not everyone, but most people if they have an upper cervical problem. I test GluteMax a lot. Because it's often not strong. And it's often strong in, about from, because it engages from here to here. But a lot of times because of our activities, it engages well from here to here, but it's not used to going here, and its tone set is just here. So it's hard to find a regular person that it can hold it in the test we were doing yesterday. Now, most of you guys are pretty good because you're young, you're healthy, you're 4 years of sitting and driving and, I give people, one of the most common exercises I give people, one of the top of the list are freestanding squats. And I have them do them against a wall so that they can't really do them wrong. They kind of have to stay in a line, and they have to keep their heels down. So some people, they got great squat motion. Some people, it's like no one ever taught them how to squat at all. I said, I want you to give me a squat. And then you got your work cut out for you. But very, very important muscle, pericardium related, takes its nerve supply from L5 and the sacral plexus, inferior gluteal nerve. So a lot of times people with gluteus piriformis issues, you want to look at some of the nutritional products that are corrected. Like we did Cytozyme F, I think, or Cataplex F on somebody yesterday, because of the glutes. There's some really great products out there. You don't have to give them. You don't have to reinvent the wheel by combining different things. Laterally rotates the thigh, extends. Long chain or open chain. It's a hip extensor. Closed chain. This is where most of our power comes from in lifting, is our glute max. Now, if it's not firing, then the small, vulnerable little lumbar muscles, which really aren't, there's not that much muscle mass there. We end up doing this, and then they get injured very commonly. So when you have your patients squat and do different things, just say, how would you pick up a box from the ground? And just watch what they do. They're doing this. Got problems. They're doing this. Either they know exactly what you're looking for, or you know that they're pretty good. They're on the right track. I don't think this was probably a problem back in the days before we spent so much time sitting. The chair is probably the worst thing we've ever done in the spine. The heel under the shoe is probably up there too, but we've done some crazy stuff that's now considered completely normal. One of them is a chair. Chairs with backs on them invite your spine into this position. We sit, usually the chair kind of cocks us back, and then we wait for the back of the chair to hold us up, and then that's where we sit. Car seats, same way. A lot of them are just like that. The newer car seats are much better. But so a lot of times when people are having more problems with sitting, I have them sit to the edge of their chair. Most chairs nowadays, office chairs will go up and down. I say, go forward, raise it up a little bit. Now you're pivoting your pelvis. You don't have to move your spine. Your head and shoulders and all this stuff is such that your muscles can work properly. And you're not creating this. As soon as you sit into a chair the way it's designed to sit in. So that sounds kind of radical, but seriously, it isn't. Really. I mean, these chairs with these curved backs are better. If you scoop back, they kind of encourage you into a little bit of lordosis. But most chairs are terrible. We have a couch at home. It's a beautiful couch. I always wanted this leather couch. I wanted a leather couch years ago. Finally got one years ago, and it's great for sleeping, It's a great nap couch, but sitting on it is horrible. It just kills my back, just sitting on it, you know, watching TV or something. So it's purely a nap couch. Okay. Max, patients. A lot of times posturally, you'll see, you'll just see kind of a listing forward like this. That's often a glute max. If you often don't, well, you do find one weak and the other one kind of strong, and then you'll see usually a pelvic rotation like this. When you stand them up, you'll see kind of like the weak backside will rotate back like this. We're going to be posture here a little bit. We can talk about that. There's Dr. Mike. That's how we did it yesterday. This person that he's testing has really good hip extension. Sometimes you can barely get them off the table, and you just test them wherever you get them. Now, if you can barely get them off the table, they probably have a really tight rectus femoris, or possibly a tight psoas, which doesn't allow them, or they're arthritic. But I test these. I've got a lot of patients, because I've been in practice so long, who have hip replacements now, knee replacements, several shoulder replacements. What's interesting, as time has gone on, and I have more and more of these people that I get to see regularly, and a lot of them have gotten the knee replacements on my watch. I wasn't able to save them. But what's interesting is a lot of times the chronic muscle weakness patterns, once they get the hip replaced, they clear, that's the best side of their body. It's like the muscles now aren't being fed all this pain information every time they step or move. And they can just do their thing, muscles can. When there's constant pain in a joint, it's constantly telling the brain that it can't handle the load, so the muscles are being told to back off. And so chronic weakness with arthritis, arthritic joints is super common. And sometimes there's the limit to what you can really do. And when they, I've been amazed at how well people do now with hip replacements, knee replacements. Actually, if they're just in constant pain and they start thinking about replacements, I'm usually pretty encouraging of it, because I know that they're not, you know, they've stopped walking, they've stopped exercising, gardening, all kinds of things. You want them to get the new joint before they've quit everything, so before they've lost all their muscle strength and tone. So anyway, make sure the knee is at 90. If they're weak, the knee will try to straighten. That's how people work. Don't let them do it. There's Dr. Rob. That knee is a little, it could be bent just a hair more, but that's good positioning. You see his arm is nice and straight. You work with athletes much. These muscles are really strong, and you don't want to be doing this. You want to make sure you're using your. Okay, lymphatic reflexes, the same as we saw with the piriformis. These are a little bit higher. I never do these. I don't do these points here at all. I might do visceral manipulation that kind of gets at these, but I don't go digging down into their friggin' pelvis. I just can't do that. Chapman reflexes right there on this occipital bone, the lambdoidal suture. Stress receptor, someday we'll talk about those, but not today. Here are your similar nutrients to the piriformis, vitamin E, remember vitamin E. Hormonal related muscle, remember vitamin E. So all of your different healthy oils, your wheat germ oils. It's amazing to me what essential fatty acids will do for people. I think that's a few years ago, that was just the rage. Everybody was talking about EFAs. I think they're very important to look at because of the poor quality of fats that people are eating in their diet. It's throwing off their inflammatory regulatory mechanisms. You guys probably know this, but like the pro-inflammatory prostaglandins, for some strange reason, the body can make those out of anything, any kind of oil, any kind of fat. But the anti-inflammatory prostaglandins, the body has a hard, it really needs omega-3s and the really healthy omega-6s to make those. It's kind of an unfair situation, but it's kind of like refined sugar. If you look at ourselves anthropologically, I think that's the word. Unhealthy fats didn't exist in the old days. They just didn't. I mean, you ate animal fat, that was it. You ate fish, fats were fresh, you didn't have trans fats, you didn't have deep fried foods. Well, maybe might have deep fried things in their fires, I don't know.
With
But-
tallow though,
Tallow,
right? Like real fat.
real fat, purely grass-fed beef has really high levels of the really healthy omega-6s, and it actually has very high levels of omega-3s. As soon as you take that beef and put them on a diet of grain and corn, those fats, they really change. So the same with refined sugar. Refined sugar didn't exist before, the modern, last couple hundred years to any extent. So we only have this one little place on the pancreas that produces insulin. There's no backup gland for insulin, like there is for a lot of other things. So you look at our design and say, well, we weren't really designed to tolerate short chain sugars. They don't exist in nature. We never really faced that in the older days. I guess, I don't know how far even you go back 100 years, I remember seeing some stats where the average American in 1900 consumed 7 pounds of refined sugar per year. Today, it's somewhere from 150 to 170 pounds a year. I mean, that's just in 100 years or so. There's no way. And then we wonder why type 2 diabetes is just exploding. It's like, it's not this. We're not equipped to handle that stuff. Anyway, all these nutrients, never overlook zinc. B6, you look at the Krebs cycle, for example, B6, B3, zinc, magnesium, just about at every station of the Krebs cycle. These are nutrients that are used up at a pretty high rate every day. B vitamins, zinc's considered the most common. I think I mentioned that yesterday. You guys probably know this. This most common mineral deficiency, I think, in our modern population. Zinc tally test, cheap, it's easy. It's kind of, the patients get a kick out of it. If you give them a taste of zinc solution, it should taste really nasty, like they want to spit it out. They're okay. Then if that's the case, don't worry about zinc. If they sit there and go, they go 5, 10 seconds and they taste anything, they need zinc, guaranteed. Look at their fingernails, those white spots in the fingernails, kind of a classic zinc deficiency thing. You look at that. My business partner, many years, he's always had kind of a sensitive constitution, and for years he had these white spots in his fingernails, and he went off gluten for the first time. I think it's probably around 48 or 49, and over about 6 months period, those white spots completely vanished. Thought that was interesting, and that's not why he went off gluten. He just went off to see, and eventually went back on gluten, and of course the white spots back. Glutamidius, I use glutamidius a lot because it's really convenient to test. I'll even use it sometimes for testing motions and nutrition and things like that. Classic with glutamidius, where the glut max kind of keeps us from going forward. The gluteus medius keeps us from falling this way. So as we're walking, the glute medius is doing this. It's eccentrically absorbing shock, and then it's concentrically powering this off. It's doing this motion here. So a classic postural sign with glute med is you'll have a high hip, because it'll kind of weaken. It'll allow the pelvis to go this way. The hip goes high. A lot of times the shoulder goes high and the head goes high. So it's this kind of like thing like this. But where glute med really shows up on it is if you can watch them walk. And then if you don't get a chance to do that, just test them. And find out a lot of times weak on one side, not the other. It's also now we're going to learn that today. This is the harder test for gluteus medius. It's if somebody has a decent glute med, but and you put them in this test, if they've got any weakness, this test will show. And
That's the real test.
that's the real test. There's Dr. Mike, and you see his patient here is perfectly perpendicular to the table. That's important. Don't try to roll and engage other muscles if you need. Once again, like the psoas, you got a lot of leverage. Gentle, just kind of rolling. Big muscle, but you got a lot of leverage. So don't kind of hold them in position until you know they can hold it. If they can't hold it, then your test is. The stabilization. He's stabilizing on the hip. Don't push right on the glute med. You're testing it a little above that on the crest. Sometimes I'll actually come up on the shoulder and kind of stabilize them that way. Reflexes once again. Here we are, right here. You work on this area. If you don't know what else to do, and go to this area and just start, bringing it up and mobilizing, trigger pointing it, and you're probably going to get some positive results. The anterior Chapmans are right here on the pubic rami. Very invasive.
I just let them
What's that?
rub it. Put
Yeah,
their
you
hands
can
there
have
and
them.
they can.
Yeah.
That way they could also do it at their sensitivity
They
level.
can't. That's a really good point. Once again, the parietal eminence. The eminence, your eminence. Stress receptors. Nutrition, once again. Oh, there's zinc again. Vitamin E. These are different products. These are all standard process, I think, products that you can pull out of your arsenal and when you start testing them. Hamstrings, you've got 3 muscles that make up the group. The biceps femoris, semi-mam, semi-ten, and the semi-mam and semi-ten insert into the pes anserine, medial tibia, which is a very busy place. Also, the liver 8, which is a commonly used tonification point for the liver meridian, sits right about just a hair above the nibble of the pes anserine. I think that's a cool word, pes anserine. Forget what it means. Some
Goosefoot.
Latin. What's that?
Goose foot, because it looks like a goose's foot.
Oh, that's right. Thank you. Yeah, Latin, right?
Question on glute medius.
Yes, ma'am.
Was there an organ related? Was it similar to glute max?
Gonadal,
Okay.
pericardium, yes.
Thank
All pelvic, piriformis, glute med, glute max, glute min, which we test along with glute med. The adductors, we haven't talked about yet. Are all related to the gonads. They're all pericardium related and gonadal related. Which also means they can be adrenal related, which also means they can be thyroid, potentially. The calf muscles, gastroc and the soleus, the tibialis posterior, are all adrenal related muscles. Sartorius, which it also attaches to the pes anserine. The gracilis, which also attaches pes anserine, are all adrenal related muscles. So biceps femoris, you'll find trigger points in these all day long if you look for them. They're also hip extensors. So often they'll be tight, not just because of poor function of the quads or their antagonists, but they'll often be tight because they're helping out the glute max. Glute max is an extensor, so are the hamstrings. The hamstrings are also, they're obviously a knee flexor, but they're also a hip extensor. In open chain. In closed chain, they're what help you stay upright. And what do we do? We do straight leg deadlifts. That's mostly hamstring. It's glute too, but it's hamstring and glute. So hamstrings are related to the large intestine, and specifically the organ. They're related to the large intestine meridian, but they're specifically related to the rectum. The tensor fascia lata is particularly related to the colon, but honestly, colon, rectum, transfer, whatever. Think colon, large intestine with the hamstrings. And also think large intestine meridian. Flex the knee, extend the thigh. It's kind of what I just said. Median lateral heads. We had a couple people yesterday that had weakness on like one, but not the other. So if we get later, when we're workshopping the muscles, feel free if we start out testing them just as a group, but then you can change your vector for medial and lateral. And that can be very helpful sometimes if you're working on it, especially with knee problem. A lot of knee problems, hamstrings. Knee problems, hamstrings, quads, sartorius, gracilis, popliteus. Something to think about if you're taking side notes. If a person has knee pain going upstairs, think glute max. Could be a number of other things, but think glute max. If they have knee pain going downstairs, think quads. That's one of those 70+%ers. Now, Dr. Rob's I usually test it a little bit higher. He's at about 33s. I tend to bring it up about 40-ish, 35, 40. I think you can test it through its full range of motion, but as a starting test, I would probably have it a little bit more, bent a little bit more than that. Once again, lumbosacral junction. So if you're at acupuncture, so you know what else to do, just stick needles in the spot. Go have a cup of tea. Probably going to help a whole bunch of stuff. I don't mean to be flippant, but honestly, this is an area that's, you get a lot of bang for your buck when you treat this area, especially at least temporarily. This is the hamstring Bennett point. So there's certain kinds of cranial fixations where you have like a jammed private bones, and often that will involve that will affect the vascular receptor. We do abdominals on somebody. We did on you, didn't we, Mr.?
No, not on me.
Somebody
On her.
on.
Kelsey.
We did abdominals. Okay.
Yeah.
Okay. We also did it on Jennifer. She's not here yet, right?
Yeah, I feel like you did it twice.
Yeah. My go-to, we won't learn that this session. I don't think I have time this session, but when we start into cranials, one of the easiest cranials to find and fix is a jammed sagittal suture. And what'll lead you there is they'll tend to have weak rectus abdominis. And it's a simple correction. A lot of times it'll bring that muscle right back. Then you got to figure out why it got weak in the first place. But there's the stress receptor. Once again, okay, vitamin E. Yeah, vitamin E also. Gosh, probiotics. I never had much luck with that. I've had a lot more luck with HCl, betaine HCl, zinc. Getting the stomach to work well. Digestion is a top-down situation. Poland, one of the common problems I find is, people don't chew their food properly. And, they end up with all these undigested weird chunks of stuff, and the body's trying to deal with all these things. The microbiome is just freaking out, and like the ones that you don't want to proliferate too much are just partying out like crazy because you have all these weird food bits in there. And caused by eating the wrong things, overeating, and sometimes the right things, and not chewing your food, and eating too much. Somebody had, you have,
Are we gonna be tested on the vitamins since they're all like pretty similar? Or-
yeah, you want to know the key ones, like vitamin E for hamstrings, vitamin E for the pelvic. We'll be going over them again too, but yeah, you want to know the basics, yeah. But once again, you want to think always outside the box too. I mean, that's why it's nice to use like the priority thing. Sometimes you get a bunch of findings yet, so you got to determine what does the body want treated first. Dr. Wally Schmidt took AK and kind of expanded into what is called quintessential applications, which is just an amazing course. His whole thing is protocols that will help you determine what the body needs first. It might need 16 things, but what does it need first? And so anyway, quadriceps. There's 4, obviously. 3 of them cross the knee. 1 of them crosses the hip and the knee, the rectus femoris. So they insert together, but the rectus has quite a different role than the other 3 quads. Of course, the rectus crosses both the hip and the knee. The other 3 just cross the knee. Upper lumbar. So a lot of times when you got a psoas issue, you got a diaphragm issue, you got a thoracolumbar, like upper lumbar jam issue, that a lot of times will interfere with quad function. So sometimes you start out with a weak psoas and you end up finding your way back to back around to the quads. Rectus femoris and the psoas are synergists to a certain degree. In gait, psoas flexes the hip, slightly externally rotates. Rectus femoris brings the knee forward without any real rotation. So they're working together all the time. And a weak psoas will often result in a overworked rectus femoris. So quadriceps, any knee problem, think quadriceps. That's going downstairs, think quadriceps. That's the test. I like a little bit more knee flexion with the starting test. So obviously, we can test it through its full range, but I would go just a little more to 90 there. There's the rectus. Originates at the front part of the pelvis, right near where the thick ligament, we call that ligament, the inguinal ligament attaches. Rectus is attached right about there. It's a busy place. There's a lot of weird forces pulling on that part of the pelvis. You'll see sometimes with a weak rectus, you'll see if it'll be on the PI side. If the pelvis is rotated back, a lot of times that rectus will be firing well because it's part of what rotates the pelvis. Not the only thing, it's part of what rotates the pelvis forward. Upper lumbar nerve supply, femoral nerve. You guys ever heard of small intestine? So on the small intestine meridian and the small intestine organ. You guys ever heard of lateral femoral nerve entrapment syndrome. It's a really nasty problem that, where people come in, they just got terrible pain right here. And the pain comes around. It's like sciatica, only it's in front. Now, that can be a very stubborn problem. That's usually caused by a TFL muscle, gets injured, inflamed, and it starts creating ischemia in the femoral nerve, which crosses underneath the TFL, kind of like the site of crossing underneath the piriformis. I've seen a lot of those over the years, and if you catch them early, you can really help them. You restore all the muscle balance. Sometimes by the time you see them, it's been chronically inflamed for months, and they can be very stubborn. And medical doctors, they inject them and they PT and they do all this stuff. And a lot of times they have to get their muscle balance restored in the pelvis. And anyway, this isn't the TFL, but it's innervated by the femoral nerve. So anything downstream, if you've got an inflamed femoral nerve, is going to be potentially affected. Anything that gets its innervation. So a lot of times people can't, you watch them engage, and they'll be walking kind of like this. There'll be one side will be, that could be all kinds of things, but if they're not bringing the leg forward like that, it could be the rectus is somehow compromised. Climbing stairs, striding balances. If you have them stand and just look at posture, a lot of times this pelvis will kind of drop. If this is a weak side, a lot of times it'll allow this kind of pelvic rotation. There's other things involved in that too, but climbing stairs. Going downstairs will reveal a lot of times weak quads, but going upstairs with the rectus, it's hard to get the leg up. Rob, with this, you want the knee less than 90. You want to start with the knee about, it's like about 50 degrees or something like that from straight. And you want to support, like we showed yesterday, you want to support the leg, make sure they can hold it, make sure their hip is at 90, and then you do the test. Dr. Mike, Dr. Can't keep a straight face, McCall. Reflexes are strangely there. It's not a point, it's like a reflex zone along the rib cage. Somebody yesterday, we worked on that. Is it you? Yeah. And then right along the thoracolumbar in the back. So thoracolumbar fixation, can often will free up the lymphatic reflexes at the same time if you get that adjusted. Right lemons, once again, mine's kind of sore today. Rest receptors. So when you think for nutrition, small intestine related muscles, which are the abdominal muscles and the quads, vitamin D. Think vitamin D. Think vitamin D. I find small intestine problems respond very well to getting people off. I've never found any supplement or probiotic or any kind of goop that will have anywhere close to the effect of getting them off foods that they're sensitive to, and very often dairy. Very often dairy. Of course, there's lactose intolerance and there's casein intolerance. Casein, literally casein allergies. Sometimes people have both. We're the only mammal that drinks milk after weaning stage. Period. Unless we feed a cat or dog. And then not only are we drinking milk, we're drinking milk designed for an animal with four stomachs. And that milk from a bovine is designed to take a calf from 50 pounds to 500 pounds in a year. And it's pretty effective. It's pretty nutrition dense. But that calf's gut is loaded with lactase producing enzymes. And also they have all kinds of bacteria that go to work on the casein. So a calf drinks milk until it's weaned, and then the rest of its life, it eats grass. So it can eat grass and it can turn it into these huge, dense bones, these huge muscles, because it has four stomachs and it has all these microbiome that does most of the work for it. We take milk, completely digestive system. We have lactase producing cells in our small intestine at birth, but they typically they atrophy and sort of disappear. And there's some interesting things written out there about different parts of the world. Northern Europeans, it's believed they were the first ones to start consuming dairy products. And of course, at first everything was fermented, so they couldn't digest it unless they fermented it. So that was developed over long periods of time. And it's believed that that humans sort of evolved over time. They sort of held on to their lactase producing cells and it got longer. And then even it's believed that a lot of us adults have, I'm not lactose intolerant. So I obviously am handling the lactose somehow. So I probably have a little bit of lactase producing, but I don't do a lot of dairy either. There's a certain amount beyond which I can't tolerate. But here we are, we've got the Dairy Council for decades now has been propagandizing the absolute essential importance of dairy. If you don't drink milk, your bones are just going to crumble away. You're just going to die a miserable death. And generations now have been brought up on that propaganda. It's absolute nonsense. Now, it's a very new, a lot of this is my opinion, but a lot of people, sure, you probably agree with me. If I was speaking to just a normal population, I'd have all kinds of grumbles and groans and questions, but you guys have kind of know, right, already. But milk is a really dangerous food for a lot of people. And it's considered, what's more wholesome than milk, right? It's been brainwashed into us that we have to have it. And we don't. I mean, we really shouldn't be having very much of it. Now, cultured milk, yogurt, kefir, all the various cheeses, I mean, those are much better tolerated because of the lactose issue. The lactose has largely been used up by the bacteria. The casein issue is still an issue. People who are frankly allergic to casein are going to have to avoid even the cultured dairy because they still have a lot of casein in it. And facciolata comes off the anterior pelvis, inserts into the proximal fibula. So it crosses essentially in kind of a weird way both joints too, hip and knee joint. It's a sort of tethering muscle. It creates fascial tightening, so the quads has something to push against when they're working. It also has kind of a tethering effect between the pelvis and the knee in gait. So it comes down and it anchors in. So a lot of times there'll be a fibular subluxation that's causing the TFL to not fire properly. I think somebody had that yesterday. Testing. Somebody, one of you guys. TFL. I always thought if large intestine, like the hamstrings. Only the hamstrings relate to the rectum, but think large intestine with TFL hamstrings. I always thought if I had opened a coffee shop near a medical school or a chiropractic college, you'd have anatomical themed drinks, like a tensor fascia latte. But so far, that's all I got. So. Fascia lata. Tensor fascia lata is one of those muscles that it's not really a mover. It's not really a prime mover. It's a tensioner, stabilizer, helper outer muscle. It'll be weak when the pelvis, often if the pelvis is out on that side. Now, it can be weak with an AS, it can be weak with a PI. But often you'll see a problem with pelvic problems. A lot of times you'll see TFL. A lot of times it will be weak along with the glute med and maybe the piriformis. Lateral knee pain. Yeah, there it is. So where the trochanteric pain, there is some fascial connection into the trochanter from that muscle. The muscle doesn't directly attach to the trochanter. Dr. Rob, internal rotation, that's key. Out, up, fully internally rotated. About 30 degrees, 30 out, 30 up is a good place to start. For Dr. Mike, doing it from a different angle, really nice setup, stabilizing the other foot. So instead of right at the lumbosacral junction, you've got kind of a zone right there that you can really work. That is the Chapman reflex area for the TFL. So if in doubt, heat, rub, trigger point, percuss, acupuncture, this area here, yeah, low back. Parietal eminence, once again. If in doubt, treat the parietal eminence. It'll affect a lot of these muscles down here that we're looking at. TFL nutrition, vitamin D. They have their ileocecal valve, which we'll talk about in one of the sessions coming up. The ileocecal valve is where the ileocecal valve, if it gets closed or open, it gets congested, all kinds of goo builds up, lymph builds up, it can be a real mess. A lot of times you'll see a weak TFL will be, especially on the right, because that's what ICD is. A lot of times you'll see TFL associated with ICD. It's a good muscle to test for ICD. It's very sensitive to that whole lymphatic renal drainage field. Okay, posture. So does anybody want to? Oh, I know what I want to show. I want to show really quick the hard glute med test, and at some point you guys can workshop it. But can somebody come up with a glute med? Be my test person. So go ahead and lay on your right side. You remember this from last year, right? Mm-hmm. So first thing, make sure they're perpendicular to the table. Make sure they take their hand and sort of stabilize themselves. This lower leg, I will bend it a little bit to give them a little bit of a tripod effect. Pick up the leg. A lot of times they'll kind of be here. I want to get them as straight in between flexion extension as I can. Hold that right there. She can hold it up there. That's pretty good. Push into my hand. Good. Now I'm going to test it. Hold. That's good. That's really good, actually. Yeah. Lay on this.
Worse than it is.
What's that?
So it feels worse than it actually is.
Well, you're probably not warmed up. But no, it holds good. I mean, lay on this side. And get them stable. The setup with this muscle is very important. They can find all kinds of ways to compensate for this if you let them hold there. Yeah, both of those are good. That's really good. Now lay on the right side again. We're not introducing this muscle this session, I think less neck, but I'm going to show it to you anyway. Somebody said, was it you, Dr. Whitney, that was talking about this test? You've never seen this?
The adductor one.
The adductor one, okay. So this is the hard adductor test. I'll teach you, when we do adductor, I'll teach you the easy one and the hard one. This is the hard one. And a lot of times you're testing the glute med, and then you just go right back in here. You bring this up here. I will hold the leg this way, hold this way, make sure they're not twisting, push into my hand. And that's not.
Dang.
Yes.
Yeah, see, I think we weren't allowed to, or when Hank showed me, we weren't holding the top leg. So the patient had to like.
Yeah.
like that.
Well, I like to give them a fighting chance.
Well, yeah, so that's why I was like, that seems very.
And then that's why you were, now, right there, now, she's pretty good. She can hold it in space, hold. And actually, that one tested really well, but this other one, now lay on your back for me. Now, this is kind of the cheat test. You have them just hold like that, just like you do a glute medius test, only you're pressing from medial to lateral. Little bit of internal rotation, hold there. Yeah, see, that shows that way too, but it's a lot of times they won't show this way. That's not bad. But if I really crowd it, I can find it. But with the other test, it's easier. It ferrets it out. Same with the glute med. A lot of times, push out. Yeah, that's pretty good. That's pretty good. And they tested good the other way too. But sometimes they'll test okay that way, but when you put them in that position, you'll find it. And depends on how bad you want to find the weakness and what other evidence you have that muscle needs to be examined. Oh, wait, come back, please. Come back. Lady, right side. It was this one that would be right. The right one.
Adductor or?
Adductor. Yeah. So just for fun. So this way, hold there. Okay, now take a deep breath in. Hold your breath.
Oh, geez.
No difference. Okay, now can you reach around, maybe stabilize with this hand, reach around and touch this would be the Chapman reflex for now she's TL. We're not really challenging it. We're just having you TL over that area there. Look at that.
Yeah, like that.
Look at that. And now, so she needs to walk around holding her back. Now we'll go real specific. We'll go right into the Chapman point itself. Yeah. So right there, we have enough evidence to go ahead and treat that Chapman reflex. Go ahead and take your hand away. And the way we treat the Chapman reflex or the neurolymphatic is we get on it and we do circular, fairly firm circular massage. Is that okay?
Oh, it's very tender.
Is it? Okay. Give me feedback. It's getting less tender.
Surprisingly, yes.
Yeah, they should. Now, if you push any point and the patient says, oh, that's getting worse, you're on the wrong point. You're probably on a neural hilus. I remember in chiropractic college, we were all treating one another, and I had this kid, I had the shoulder thing going on. And he got on my neural hilus on my scapula, and oh, there's a problem right there. And he's just digging away. And of course, the longer he pushed, the more it hurt. But a Chapman reflex should, is that better?
Mhm.
Do you feel any pain now?
It's still tender, but not as bad.
Well, let's just go in. Now, if I was in my office, I'd grab my percussor with the round head on it, and I just sit there and would just sit there and work away at that. Saves my hands.
Oh, yeah, maybe you should turn around so they.
Oh,
can
that's
see what
right.
You're doing.
Yeah, you're absolutely right. Now I get dyslexic. It was this.
It was the other one.
Yeah, there it is. What's that? Something. Breathe in and out. Deep breath in. What's the breath do? The breath moves lymph. It moves those main lymph channels that come up underneath. It's no accident that the cisterna chyli, the main reservoir for the lymph to pool from the lower half of the body, is located at the back of the body wall right near the diaphragmatic crura. It takes advantage of that pumping action back there. How's that? Not too bad. Okay. Lay in your
Look again.
right side again, please. And hold there. Push, push. Yeah, that's way better. Now TL it again to see if we missed something. That's what the Dr. No, that's good. Blake, one of my first AK teachers, said call that 51%. We got it, but it's if you add another little factor, there you haven't got it all. So anyway, so we TL and then we specifically TL'd the Chapman and we treated it, and the muscle turned on. Maybe that's all it needed. It might need more, but that's all we need. So here is our some examples. The blue book has pages of examples of these stick figures indicating what you'll find on posture and what it indicates. I have a few here, but the blue book is full of these. So here's that gluteus medius, high, high, high. This gluteus medius, that might be on your test. High, 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 gluteus medius. Yes, sir.
So that would mean the other side is weak.
It would mean that this side is weak. If it's weak, it allows this. And you think of this, if we do this, the pelvis doesn't do this so much, it does this. It's like it's in a bowl. So when this happens, it naturally raises that. And then if there's, a lot of times the patient will then compensate this way. So, and then, they'll do all kinds of things. So, but with the classic blue knee, it's, an uncomplicated blue knee weakness, you're going to have high, high, high. Over here, you got your abdominal oblique. That's a little harder to ferret out. Abdominals are, any kind of torsion in the torso is, you want to suspect, obliques. The obliques are very important muscles. They're often overlooked. The six-pack is a big focus for a lot of people, but the obliques are a much larger area of the torso, and they're involved in all kinds of movements. Also, the obliques kinetically tie in with things like the serratus anterior. So, just here's a lat, uncomplicated class. Uncomplicated weak lat allows the shoulder to go up. Now that could also be a tight trap. Usually you'll have a tight trap and a weak lat. This is a psoas imbalance, and that's where the uncomplicated. Usually there's more things going on, but they'll just be kind of like this. And sometimes it'll feel like they've got some scoliosis going on in that area, and often they do. Scoliosis is. I have a young lady right now I've been working on since she was about. I think she's 15 or 16 now, but I've been working on her since she was about 11. And she has upper lumbar scoliosis that is developing, and her mother has it too. It's not too bad. So I see her about once or twice a month. And the main thing I'm doing is just adjusting everything and making sure her psoas muscles are balanced. And I don't know if I can prevent it. It's not getting any worse right now. It hasn't been for a year or two. So I'm hoping that what we're doing is making that difference. I had another patient some years back. It was a young lady who I treated. She was screened at school or somewhere as having the onset of scoliosis. Her mother brought her to me. I treated her through puberty. She just not into puberty, just going in. I treated her clear into like age 14, and she was a basketball player, athletic. And we actually improved. She was getting regular scoliosis x-rays, and it actually improved. with, and then they moved away and I lost track of her. So, but, if you halt the development of scoliosis, you don't know if you fixed it or not. You know that, because sometimes they're self-limiting. They'll start to torsion. So it's kind of like, if you prevent someone from ending up with back surgery, you don't know that because they never had back surgery. You can sort of theorize that if you get adjusted and you keep your muscles balanced and you do all the right things, that will keep you from ever having to have back surgery, but you don't know that for sure. You can't prove that. Okay, so sternocleidomastoid, we're going to do this on each other. We'll have fun with it, but tight one here, weak one here. It's going to allow the head to tilt. Teres minor, which we haven't really done yet, but teres minor, people with that walk like this, their palms are facing backwards, or sometimes they're walking and they'll usually, you won't just see this isolated. You'll see they'll have kind of a gait thing where one arm's moving and the other arm is just kind of doing this. They've had a shoulder injury, they've had who knows what, maybe elbow stuff, but their palm will be facing back because the teres minor is keeping their shoulder in external rotation. So that's kind of a typical one you see too. Dr. Francis, he had all these, he said, now if you see somebody walking like this, think thyroid. Because teres minor is a triple warmer thyroid related muscle. They got a thyroid. They walk. Made a really good argument. So let's stop there and when is it? Wow. Oh man, sorry. Carried away there. Let's do a break, water, whatever, and then we're going to do posture. And